Not doing that dance.
We got our dance going on here with the music.
He's doing the Trump dance.
I got the Trump dance going.
He's got the Trump dance going.
Welcome, everyone, to PerfWeb 103, day 5?
Yeah.
Day 5?
Yeah, day 5.
I think it's day 5. Is it day 5 or day 4? Day 5. Very good. Okay. So I'm your host, Joe Bosch. I'm here with my esteemed colleague and co-host, Dr. Samir Patel, perfusionist and physician extraordinaire. Let me go through our opening remarks, if I may. Contact us. You can do so at contact@perfusioneducation.com. Please call us or send us an email, whatever it is, and let us know if there's something you would like us to discuss. I did get an email, but it was all about pediatric, and I just don't do pediatrics. So it's going to have to be adult, ECMO, NRP, anything. Even I don't even really feel like I would be remotely qualified to discuss adult congenital, because it's
hard.
just I don't understand it very well.
Right.
I mean, I may have a very basic rudimentary understanding, but it's not what I do. So
Sure.
I feel I would be doing a disservice to try to muddle
Correct.
through something like that.
Right.
But there's how you reach out to us. We no longer have a call-in number because nobody ever called it, so that's scratched out in red and a big X in it, which I think everybody's really happy with, but I miss it. I liked it, and I just wish people would have actually used it. The Chiron that you see there will be on intermittently throughout the program, so you can figure out a way to reach out to us. And of course, Magic will be doing all of the social media today, including the YouTubes. So you can send a text message or a message there, whatever they call it, chat, I think they call it. And he will try to get those questions up if you have any. I do want to discuss very briefly our MediWeb app. You can find it on the Apple Store, the Google Play Store. It's a $2.99. It's a really good app. We're starting to sell more of them. We're gonna raise the price. So if you had any interest in getting this app, now is the time to do it. We spent a lot of money developing it and having it built and keeping it running. And thus far, we've been selling it for a very, very low price. But it's, I'd like to at least recover my expenses on that. If we could sell 1 million of them, it'd be great. I could probably retire, but I don't think we're going to ever get to 1 million. But it'd be really nice to get a few thousand sold. PerfWeb podcast, you go to whatever your favorite streaming platform is, Spotify, Podbeam, or Podbean. Is it Podbean or Podbeam?
Beam.
Bean, as in like a green bean? That doesn't make any sense. Podbean made more sense to me.
Green peas come in pods, Joe.
Understood. That's just true. But
I'm assuming that's the segue.
But you're beaming out the podcast, so
Beam
Podbeam
would've made more-
makes more sense
Hey,
to
buy
me.
the space, Joe. Somebody may buy
But
it
it's
from you.
not a. But it can't be a beam because it's actually a wave,
Right.
and therefore it would have to be pod wave. You'd have to come up with a new one, right?
There you go.
But you can listen to us whenever you'd like and go from there. Okay, we're going to just jump right in, and this is how we're going to do this today. Go ahead and throw the slides up. But this is, our topic today is when is enough enough? Essentially, I'll kind of set the scenario up for you. You have an ECMO patient. They just look terrible. They're in multi-organ system failure. They're on CRRT. Their liver enzymes are up. They're bleeding out of their mouth. We've all seen it, right? And for those of us that do ECMO, we've seen this scenario. And we sit there, and I have done it myself, where I'm like, what are we doing here? Why are we continuing with this? This is a terrible disservice to this patient, to this patient's family. I don't know why we're doing this. And then patient leaves the hospital under their own power.
Yes.
And it makes me take a real big, giant step backwards and reevaluate a lot of what I think, right?
Right, yeah.
Because it's very unsettling. Oh, I need a new mic.
But I feel like how much does that actually happen,
More often than I'm comfortable with.
Okay.
I've had that happen enough times that it has concerned me.
Sure.
So I've sort of stopped doing that.
No,
Now,
I've seen it recently. I mean,
now I will say that I mean, if you just were to take the percentages, I would say I'm probably 90%
okay.
accurate, 10% wrong, but that's a lot.
That's a huge
Especially
number in the medical
given-
world when you're talking about lives.
Yeah, especially given the number of ECMOs that we do.
Correct.
So thankfully, I wasn't the decision maker on those. But then on the other hand, I don't think it would be improper of me or unreasonable of me to say that there have been times where I have been it is so incredibly obvious. Now, where I think it becomes truly obvious, because again, I've seen hearts come back.
Right.
I've seen kidneys come back. I've seen people's bleeding out of their mouth just stop and get better. We're just packing it and dealing with it and doing transfusions. In fact, Vicky Carlisle yesterday gave a talk on 6 MTPs. Now that patient does have a neurologic problem, I do believe.
He or she does.
Yes, she does. Yeah. But we didn't know that. That was not known.
Right.
Right. But her heart actually, from a hemodynamic perspective, every other organ system perspective, is pretty normal.
Yeah.
And that's really amazing to me with what happened. So the fundamental question is, and this is, I did some searching around trying to find some appropriate resources for this, and this one was very provocative. I found this one to be really interesting. Is it ethically justifiable to withdraw extra ECMO support against the wishes of a patient with decision-making capacity when cure is not possible? What the hell are we doing?
I think that's what it is. You just bent some antenna or something, and we can.
Okay, is it working now?
Yes, it's working now.
Okay, I'm sorry. Okay, I'm sorry, everybody. Forgive me. So that's the and this in this particular point counterpoint, this author says yes, and let's explore it if we may. It is well established that clinicians, and I'm going to read a lot, so please be patient with me. It is well established that clinicians may decline requests for inappropriate interventions, including life-prolonging interventions. This position is supported by major professional organizations, statutes, and regulations, and in fact, case law. As such, the open question is whether providing ECMO may be considered inappropriate care when cure is not possible. In 1991, the American Thoracic Society specifically supported the physician's ability to withdraw life-prolonging interventions over the patient's objection when the intervention would be highly unlikely to result in meaningful survival. Highly unlikely and definitely won't are two completely different things, and I will just go back to
the word meaningful.
Yeah, that's subjective,
very
right? That's
subjective.
extremely subjective.
Extremely
But this
subjective.
goes back to what I said earlier: is
Right.
what I've been wrong. I've been wrong too many times.
Right.
In 1997, the Society of SCCM, Society of Critical Care Medicine, supported the clinician's ability to withdraw interventions that are deemed inappropriate. In 1999, the American Medical Association (AMA) supported a process-based approach to unilateral decisions to withdraw interventions. And in 2015, the 5 leading critical care organizations in North America and Europe published the multi-organization policy statement on responding to requests for potentially inappropriate treatments, which provided a robust 7-step process for considering such decisions. Most recently, in 2016, the SCCM provided guidance regarding when such decisions may be appropriate. Because the multi-organization statement allowed for a truncated process when there are significant time constraints, the SCCM Ethics Committee was compelled to provide guidance to ensure providers do not unilaterally limit or withdraw interventions inappropriately when unable to complete the entire 7-step process. And I think this is something really interesting that actually predates COVID. But were it not for this, because during COVID, there were some real hard decisions needed to be made.
Sure.
We have somebody over here that has a very high likelihood of survival. This one, it's iffy. What do we do here? Do we keep this going and not provide it to them, or do we pull it on this one and go over there?
Correct.
And that is a real ethical dilemma. Look, we talked about NRP. We've kind of going down the ethics rabbit hole here lately, right?
Right.
And so
that's exactly what we're doing.
Right. But I think these are really interesting conversations to have, and they're conversations that I generally don't daily really confront.
No, I think a lot of us try to shy away from even thinking about these decisions. you
Yeah,
know?
right.
I mean, in a general
it's
sense,
not
it's
our-
not just us, doctors, nurses.
Well, it's not our
everybody.
role typically in what we
Correct.
do,
It-
right?
it's not.
But certainly there is a difference in enthusiastically treating patients versus just going through the motions. I mean,
Yeah.
we do have an impact, and
Absolutely, a huge one.
and we are absolutely human,
Right.
and
And we have a voice.
we have a voice,
We have a
absolutely, we
voice,
do.
you
And
know.
sometimes when we do see somebody being literally tortured, and that happens more than does the ones that I'm sure aren't going to make it that do. I mean, it really at the end of the day, that the former, or seeing patients clearly that have no outlet at all.
Sure.
And we just keep going and going and going
Right,
and
right.
going and going
Yeah.
until they finally declare themselves is very problematic. And a lot of that has to do with, I think, just poor communication. You have one intensivist that's here this week. They're telling the family something. Another intensivist comes in, starts their week, and they tell them something completely different.
Yep.
The family becomes very confused. We become very confused. We don't know what the plan is here. And there's a lot of plan. It's weekly plan change.
Correct.
The plans, the what we're going to do with this patient, what our treatment goals are, changes weekly.
Exactly.
And
drastically
sometimes
so.
and sometimes drastic, and sometimes daily.
Yeah, sometimes
So these are
daily.
concerns, right? Because this multi-organization statement allowed for, okay, we discussed that already. ICU interventions should generally be considered inappropriate when there is no reasonable expectation that the patient will improve sufficiently to survive outside the acute care setting, or when there is no reasonable expectation that the patient's neurologic function will improve sufficiently to allow the patient to perceive the benefits of treatment. SCCM was clear that there is no obligation to limit or withdraw interventions in such cases, and further clarified rather, that this definition is not exhaustive, which is also very important. Look, if you have a patient that has a massive ICH with herniation, okay,
Yeah,
they're not going
gonna,
to make
yeah,
it.
they're not going to make it.
Okay, but
And even if they do make it, what are they going to come back to?
they wouldn't.
They
They'd
wouldn't. Yeah.
nothing. So,
Yeah.
but the family may not want it turned off.
They rarely do,
And
Joe.
no, man, no, no. I've seen them. I've seen it where we've had them 3, 4, 5 days
Really?
longer than what should. But this is a catastrophic injury,
Especially
and-
with herniation.
and
I mean, that's huge.
and everyone in the facility, every medical practitioner in the facility would have had more than ample protection, authority, and protection to say we're stopping. But they don't. And some of that's political. Some of that is pressure from a variety of different places.
Right.
Including, even though the lawsuit would not be successful, the mere fact that you have to endure it
Right.
gives us pause. And that's another issue, probably another topic, is to discuss medical malpractice and how we have become very defensive in how we practice,
Right.
because of that ability to sue so easily.
Oh, yeah.
And I fault our legal system for that.
Right.
Our injury lawyers, if you will. As such, there is broad agreement that when a patient will never be able to survive, okay, I just said that already. Furthermore, this position is consistent with guidance from ELSO, the major professional organization for ECMO centers. also states that having a condition that is incompatible with normal life or that carries a fatal diagnosis are contraindications for ECMO. Clearly, being unable to survive outside the ICU is incompatible with normal life and would generally be considered a fatal diagnosis.
There you go.
Now, this gets even more complicated because just because you can put them on ECMO doesn't mean you should put them on ECMO. And not unlike these cases that I have been wrong about that I didn't think were going to survive that did, quite surprisingly to me, I've also been confronted with, I don't think we should offer this patient ECMO. I think this is a bad idea to offer this, put this patient on ECMO. We're going to have a dead patient on ECMO. And I've been wrong there too.
Correct. Okay.
Right?
Right.
And so but I've been right more than wrong.
Right.
But being wrong is unsettling.
Sure. Because
Right.
again, we're talking about a life here, right?
Correct.
Yeah.
Because ECMO currently requires ICU care, ECMO as destination therapy is generally not offered. This could change in the future if outpatient ECMO becomes a reality. That would be ECPR. It would be what the French, the Paris experience, putting people on ECMO out in the field that have sudden cardiac arrest, that kind of thing. If the patient presents to the ICU with a lethal condition for which no long-term treatment is available, such a patient would not be considered an ECMO candidate. To not offer ECMO in such cases is commonplace, and when such patients or surrogate decision makers request ECMO, they are generally told that ECMO is not an option because of the terminal condition. At times, however, providers may believe that cure could be possible, and the patient is placed on ECMO only to later find that they are not a candidate for the long-term options. In such cases, the patient may already be on ECMO and may wish to remain on ECMO in the ICU despite no options that would allow the patient to ever leave the ICU environment. And I have seen people on ECMO for over a year.
Yeah, it's called the bridge to nowhere.
The bridge to nowhere. It is definitely.
It starts off as a bridge to something, but then
Mm-hmm.
becomes quickly a bridge to nowhere, right?
But in defense of some people, some practitioners that make the decision to put people on ECMO, that because you don't have the luxury of time.
Sure.
Time time in these circumstances is not on your side.
Right, and you're making these decisions very quickly and under a lot of pressure.
And you take into consideration the patient's age, relative health, family structure, comorbidities, all of these things, and it's all happening in an extremely compressed period of time.
Correct.
And of course, a lot of it has to do with what is the story that they're being given. So even before the patient gets there, we're coming in, blah, blah, blah. This is a young person, otherwise healthy, yada, yada, yada. They get the information and they're predicating a good family start. They're predicating what's going to happen before they, on that information, before they ever really see the patient and know the patient, only to find out a lot of things were not communicated, maybe weren't known, or were just essentially miscommunicated.
Sure.
And these can be serious problems with this. And families saying, I want my loved one to live, and I know you have ECMO, and I want them to be on ECMO. And now you have that added pressure, right?
Right.
A lot happening in these cases. In such cases, however, the decision to withdraw ECMO over the patient's objections may be ethically supportable if the institution follows the 7-step fair dispute resolution process. Now, I got to tell you, that's a mouthful of garbage, garbly goop, whatever you want to call it, because the person is definitely able to talk and communicate and is saying, I don't want to die.
Right.
But you have no pathway forward. You will only be here on ECMO until you get an infection, something's going to happen.
Right.
But you're not going to live a normal life. This is all you will ever have is right here. I don't care. I don't want to die. Dude. And this guy's saying, yeah, but in this case, you just follow this 7-step process, and we're going to go in there. We're going to tell you, well, sorry, but you need to say your goodbyes now, dude. I'm not going to. Who the hell would do that? Who could do that? Could you?
No,
I couldn't.
I'm glad we're not that guy.
But who would? This guy is arguing, yes, Who is he? And I'm sure he just took the position because he had to. I don't
Yeah.
even know that he feels that way. But Alexander A. Khan, MD from Missoula, Montana. I don't know how many ECMOs he sees, but man, I'll tell you what. I don't know, man. I think it'd be really tough. So, ECMO would not be. So here, let's see. Where did I end?
I think you're up.
Following the 7-step process ensures broad agreement within and outside the healthcare profession that the requested treatment is indeed inappropriate. The steps include ensuring optimal communication to attempt to resolve the dispute. You're going to die. I don't want to die. No, we're going to make you die. No, we're going to take this away and you're going to die. No, I don't want to die. I mean, that's the dispute. Seeking consultation with other professionals within the institution to evaluate whether they would be willing to assume care, and if not, to assess their concurrence with the determination that the requested treatment is inappropriate. Review of the case by an interdisciplinary hospital committee that should include members of the general public to assess whether there is broad agreement, including the agreement of the general public, that the requested treatment is inappropriate, making a good faith effort to find other providers at another institution that would be willing to accept the patient and transfer and provide the requested treatment, and ensuring that the patient and family understand their right to appeal the decision in a court of law at any point in this process. If others believe that it is not ethically permissible to draw ECMO from the patient, ECMO would not be withdrawn. Now, I'm just going to tell you right now, there's no court that's going to say turn it off if the dude's talking.
Yeah.
I mean, and if he's insured, maybe somebody will take him. But if he's not insured, he ain't going nowhere. He's under-resourced. He's not. We just had that happen with a kid that had insurance, believed he had insurance, okay, from, where was it? Somewhere in Colorado. It was a school, a college type of thing, insurance that was only good for that area.
Oh, and not here.
And people don't understand this.
Yeah.
And we could not get that kid. This kid had he had cystic fibrosis, and he had a major. Remember the kid that we're talking about? A major flare up.
Yep.
And it was decided to put him on ECMO. He had a crisis, and we couldn't get him transferred. He needs a lung transplant. He does, and he was eligible for a lung transplant. He'd be a great candidate for a lung transplant, but no one would take him because his insurance was only good in that place in Colorado, and we couldn't get him transferred on ECMO because of some other insurance issue. So ultimately, and I have to give a lot of compliments to even some physicians that I don't particularly care for that much. They stuck with it, and they got that kid off. Yeah. And that kid is back in Colorado, and he survived. He was 19. This kid was 19 years old. 19 years old.
I was there with him.
And
in
he
the
didn't.
ICU.
And he didn't want to die.
No, he didn't. And his mom was really sweet too.
Yeah.
Man. His mom was like such a sweet.
And so I have to give my compliments because there were a lot of people saying, "Do not put this kid on. Do not put this kid on. Do not put this kid on." But they did. And there was a lot of blowback because of that. But ultimately, it was the right decision. It was the right decision.
You ended up taking him personally,
how long
too.
would be required to care for the patient in the ICU? So with advances in ECMO, and this is very true, it is possible that a patient could survive months or perhaps years on ECMO. This is very true. How long would be required to care for the patient in the ICU? ECMO is a limited resource based on the number of pumps, personnel, space, and so forth. What if other patients who have a reasonable chance of cure are being denied ECMO and are dying while this patient is living in the ICU on ECMO? What if the staff's moral distress is leading to nurses transferring to other units or leaving the institution? What if the provider's moral distress is leading to intensivists leaving the facility for other positions?
Gosh.
There may be compelling reasons to withdraw ECMO even over the patient's objections. Furthermore, there is no rationale for signaling out ECMO. As such, if we were to disallow removal of ECMO in such cases, we would necessarily need to agree that no life-prolonging intervention could ever be withdrawn over the patient's objections. This would certainly include mechanical ventilation, continuous renal replacement therapy, or dialysis, and so forth. Additionally, there is broad agreement that there is no ethical difference between not initiating and withdrawing an intervention. Indeed, the American Medical Association states, while there may be an emotional difference between not initiating an intervention at all and discontinuing it later in the course of care, there is no ethical difference between withholding and withdrawing treatment. I fundamentally disagree with that. I don't know what your position is. I fundamentally disagree with that. I think there's huge differences in ethical conundrums with those two things, to be frank with you. But I'd like to get your opinion on that.
No, I agree.
Who's going to walk in and turn it off?
Exactly.
Who's doing it?
Who's doing it? Yeah, exactly. No, I 100% agree with you on that. I don't think, no.
Not doing it is not anywhere close to the ethical dilemma that I would be confronted with versus like sitting there saying, what do you mean you're not going to put them on ECMO? Please put them on ECMO. This patient is salvageable. No, we just don't think so. We're not going to do it, and that's it. That might be hard, but not as hard as walking in and saying, "Look, Samir, I'm sorry, but
we have to stop your
we're
ECMO.
done.
Done.
I'm clamping the line. I'm not going in there and clamping it.
No,
you're the one that wants it off. Whoever the provider is, administrator or whoever it may be, you clamp it. I'm not going in there and doing it.
Right.
No way in hell.
They're not at all the same. For them to even say they're the same is ridiculous.
Yeah, I don't know how this guy came up with these arguments. I feel bad for him because I think he got to sign this. There's no way he actually just volunteered for this. Yeah. As such, if we were to disallow the removal of ECMO over patient objection, we would need to disallow not offering ECMO to any patient. By extension, I don't agree with that. By extension, we would then need to disallow not offering any intervention that might prolong life for any amount of time to any patient, regardless of the patient's prognosis. Disagree with that fundamentally.
He's dealing with so many absolutes,
Under such a system, any patient could demand any intervention that might prolong their life, regardless of whether such treatments were consistent with good medical practice. This would represent a radical shift in how we practice medicine. We, the ICU experts, would no longer be able to determine what constitutes appropriate treatment. When a patient requests an intervention, we would be obligated to provide that intervention. Furthermore, because failure to offer an intervention and rely on patients and families to request the intervention greatly privileges one class of patients: white, educated, wealthy patients who research their condition and are comfortable demanding interventions that the physician has not offered, over disadvantaged patients, e.g., or such as those of minority status, those of lower socioeconomic status, those who are uncomfortable confronting the doctor, those who do not speak English, and so forth. We would be required to offer any potential intervention to all patients. Such a system would be inconsistent with long-held professional ethical standards and practice. As a pediatric intensivist with over 20 years in practice, I have had only a handful of cases in which parents of a child who is neurologically intact requested withdrawal of life-prolonging interventions. I remember every one of those cases vividly because they were so difficult for me and for the other members of the ICU team. As a certified ethics consultant with over 20 years' experience, I have never had a case in which the ICU team requested withdrawal of life-prolonging interventions over the objection of a competent patient. Personally, I cannot imagine a case in which I would push to withdraw life-prolonging interventions over the objection of a competent patient. However, that does not mean that there are no such cases in which doing so would be ethically permissible. Although withdrawing ECMO, well, see, he's trying to have his cake and eat it too. Now,
yeah, I was just about. He's like a 180 here.
You noticed that he just went into
like, what?
He just went into reverse at the exact same lightning speed. Light speed. Yeah, that's rapid. That was very rapid course correction. Although withdrawing ECMO over the objection of a patient who is cognizant and communicative is uncomfortable based on longstanding ethical and professional norms and practices, it can be ethically permissible when there are competing ethical considerations. Clearly, such cases must be handled with great care and tact, and there must be a robust process in place to ensure excellent communication and deliberation. Dude, that's rough, dude. That was tough.
His closing.
That was tough.
He lost me at the closing.
He lost me too.
Yeah.
So now we're gonna go.
I was fully against almost all the things he was saying, but then I agree with his complete closing. You can't give that kind of power. obviously, to a patient because they don't know what's best for them. They're not educated enough to know that.
But at the same time, and
But
we've
they wanna
talked about
live.
this. Well, they do, but again, one man's trash is another man's treasure. Remember
This is
that,
true.
right?
This is true.
And so, with the NRP, you have a patient who has a
Right.
hangman's fracture. He can only move from his chin to his forehead. That is
Right.
all he's got. He, whatever the case may be. That's it. And then they want to die. They're like, I don't want to, they don't want to live like, they can't even move their head. They don't want to, but they can mouth, they can communicate in some way.
Right.
And they're like, I'm done. I want to donate my organs. And we take them and we take the ventilator away. They die.
Yeah, they
because
do.
they can't breathe on their own. They're vent
No.
dependent, right?
Right.
Trached and so forth.
Right.
So,
Yeah.
so I mean, we do see it, and these are real. This can really happen, right? And there are some people that have tremendous ethical challenges when it comes to NRP and that very case.
Right.
But again, what is quality of life, and it is incredibly subjective.
Oh, that's where it lies, the subjectiveness of it. And I feel that personally, that's where I feel like families don't concentrate enough on that. They want their, me, working in a stroke center, I've seen this, Joe,
Yes.
so much. They want, the patient would be out, right? Like they had a massive stroke. They're out. They're like, save my loved one, save my loved one. We saved their loved one, through whatever burr holes, whatever the case may be. We had to do crazy stuff to make it happen. The loved one wakes up and they can't speak, they can't move half their body, and they don't want to go on. You can see them crying. Like they themselves don't like the quality of their life, but the loved ones, they're like, save our loved one, saved our loved one,
Yeah.
So
yeah,
I feel
like,
like that's a big
so-
disconnect,
Yeah. And
Personal wishes
Well-
versus what our family's wishes are,
Exactly. Well, remember the Shivo case?
Which one's
The
that?
one down in Florida with the girl that was in a persistent vegetative state.
Oh, yeah.
And the parents believed
That
she was actually like able to know they were there, but the husband had said that she did not want to live like this, that they had discussed this.
Correct.
And he is who had standing.
Yeah,
and
he's
they
he had
fought
the
that
POA.
all the
Yep.
way to the courts, man. That went all the way through the courts. Took forever. But they finally did take her feeding tube out, and she was allowed to
Because
die.
the husband ultimately has the call.
Right,
He
but
is the next of kin, the power who has the POA in
Yes.
those situations.
correct.
Right? So,
Yeah, they have standing.
Right.
That is correct.
Yeah.
So now we're going to see the same question, only this time no. Andrew Childress,
doesn't pull a
PhD.
180.
No, listen, let me tell you something. I'm going to tell you right now. I would have much rather had to defend this position. So I think
Right.
Andrew got the better deal here.
Oh, he's from Houston.
Yeah, from Houston.
How
right.
about that? Okay.
Physicians often place, and this is pretty contemporary, by the way. This is fairly recent. Physicians often place patients on ECMO support because they expect them either to recover with additional support or to become candidates for transplant or mechanical circulatory support, or MCS. If these goals are not met, they may view continued ECMO support as medically inappropriate and recommend its withdrawal. In cases where decisionally capacitated patients object to the withdrawal of ECMO support, it is not ethically justifiable to do so over their objections. I will offer 4 arguments supporting this claim based on considerations of medical futility, quality of life, non-malfeasance, and informed consent. Continued ECMO support is not futile. The futility of an act or process must be considered in relation to a particular goal. In its most basic form, the concept of futility describes a situation in which the means chosen to achieve a particular goal simply will not accomplish that goal. In the clinical context, futility is taken on several different meanings, such as physiologic, imminent demise, qualitative, quantitative, and so forth. Many physicians would consider failing to meet the goals listed above as sufficient evidence that continued ECMO support would be futile. No matter what the initial intent intended purpose was ECMO as a treatment option only makes sense if it aligns with the patient's goals. If the goal of living a life that the patient finds meaningful or even minimally acceptable can still be met with ECMO support, then it is not futile to provide it.
I agree with that.
Notwithstanding,
I agree with that.
the other person's argument that we have limited pumps, limited resources, they're going to take this up and we don't have another one in case somebody else does actually need it, especially in low volume accounts, right? Or low volume hospitals that don't do a lot
That
of
only
ECMO.
have maybe one or
But when
two.
you're in rural
Right.
Montana,
Right.
you know,
Yep.
anything can happen,
Sure.
right?
Right.
Quality of life, QOL. Although some healthcare providers might find the benefits to burdens ratio unfavorable, they are not the experts in determining what the patient should consider an acceptable quality of life. Absolutely true. Physicians' duties are to ensure that patients can make their own decisions about treatment based on their idea of a good life. Although there may be some objective components that factor into an acceptable quality of life, for example, experiencing positive mental states, preference, satisfaction, and various objective goods, there is no consensus about how to prioritize these components. Respect for patient autonomy requires that medical professionals trust their judgments about quality of life. Trust the patient's judgments. Avoiding cruelty in medicine. Let us assume that the team provides sufficient ethical justification for removing ECMO support from a conscious, capacitated, and objecting patient. No matter what argument might be offered, actively withdrawing ECMO support in this situation would go beyond violating the principle of non-malfeasance. Such an obvious lack of compassion would be cruel. It should go without saying that cruelty is unethical. It is hard to imagine that physicians would be willing to cause this level of psychological harm to both the patient and the family. However, professional guidance statements may permit setting limitations or interventions that are not expected to enable the patient to leave the hospital, or withholding interventions that may achieve important patient-centered goals but are not justified because of other ethical concerns. Healthcare professionals may argue that their primary intervention would be to compassionately relieve suffering or to prevent future suffering. However, this intent is misguided if the patient denies that they are suffering or argues that they are willing to bear these ICU-related burdens. It would be contrary to professional norms for healthcare professionals to participate in an act that not only does not relieve suffering, but also causes it. I mean, emotionally, that would be pretty. They're walking in, they're coming in now to do it, they're going to disconnect me. I mean, I can't even begin to imagine the terror. That's almost, I mean, that would be
not
worse
go
than,
like that.
that'd be worse than going into the death chamber for a
be
crime that you didn't commit. It's the same thing.
It's the same
I mean, it's the same
It's
thing.
the same thing.
One can only imagine how such an act might tarnish the reputation of the medical profession. Even physicians are understandably reluctant to actively withdraw ECMO support. Declining to exchange the ECMO circuit if it fails or to treat other complications may have the same effect in terms of psychological harm and loss of trust. And that is something that we have
some serious points, though.
Dude, but we have seen this,
Yes.
okay, where we have been, the family
Right.
doesn't want to withdraw. It's not the patient, but the family. We don't want to withdraw support. We don't want to withdraw
Right.
support. But I've heard the conversations. Look, if this thing fails, we're not changing it.
Right.
Okay?
Right.
If they're not going to get better, we're going to just, it's not going to work. If this fails, the circuit itself, and then we're going to have to see if they're going to be able to tolerate being off, but we're not going to change it and put another one on.
Correct.
And a lot of times the families are okay with that.
Okay, you mean like an oxy change out or something
Yeah.
like that? Okay.
Mm-hmm.
Okay.
Yes,
Okay,
yes. But at the same time, you know, we're talking about two different things here, apples and oranges. Patient is awake, patient's able to communicate, patient's able to say what they want, versus, and they are actually sentient, like they can have a conversation here, right?
That's tough when they are.
You know, they're contemplative, right?
Right,
Whereas one, they're not, and they're really failed. There is futility. The
Right.
family just wants them to stay alive. even if it's on ECMO, but
Right.
there's no meaningful existence
Right.
in anybody's, only in theirs, not
Right.
in the patient. They
Right.
can't even communicate. They're non-communicative.
Correct.
Precedent of prior agreement. Clinicians may assume that because the patient consented to ECMO support for the purpose of pursuing curative treatment, they are under no obligation to continue to provide support when cure is not possible. Clinicians may further assume that consent for decannulation was given as a condition of cannulation. These assumptions not only are incorrect, but they also raise questions about paternalism and the potential for coercion. As Show and colleagues note, true consent for decannulation could not be properly achieved before cannulation, as consent might be given under duress. Patients may feel pressured to agree to these terms if they think the team will otherwise refuse to offer ECMO support. Setting clear expectations for what ECMO can and cannot achieve is essential to obtaining informed consent. That is also for the family. In this case,
I agree. I think
in
it's
this-
more for the family.
In this case, they are talking specifically about an awake patient
Correct.
who can
Make
make
his own
their own decisions.
decisions,
But
right.
but that concept
Right.
also, I think, translates to the family. Look, your loved one, we're doing CPR. This has been a serious event. We can put them on ECMO. We can provide that. It can buy us some time. It may work. It may not work. It can't be. But once you leave that and you start saying it can't be open-ended, we can only do this for 5 to 7 days. If they don't recover, you have to agree that we're going to be withdrawing it at
Yeah.
that point. That would be coercion.
That would absolutely be coercion.
Right.
Well,
Not
I mean,
intentionally.
No, of course not.
It's not
yeah,
intentional,
it's not
but it's
intentional
still
but
coercion.
It's still coercion. I feel like if the patient is awake and is talking, it makes the whole thing a lot. At least if you're talking about qualitative futility, you know what I mean? Because they'll tell you if they're happy with the quality.
Sure.
Right? They'll
They
tell
can
you,
tell
I'm
you.
good. I'm
Yeah.
good with my left
Look,
side not working.
I'm
That's
okay.
fine.
Well,
Right?
that's different than I'm just on ECMO and I can still play video games.
Right,
I can
exactly.
still watch sports games. I
Exactly.
can still visit with my
Right,
family.
right.
Man, there's a lot to unpack there in
There
this,
is a lot,
really
yeah.
a lot to unpack.
And quantitative futility, that's a little more harder to get into.
Yeah.
you know what I
And sometimes
mean?
it just goes on and on and on to the
That's
point where
why,
they just
yeah.
say, okay, I'm done.
Exactly.
I'm done. I want it off. Just go ahead, do it now.
Yep.
Give me the clamp, I'll clamp it myself.
Dang.
But
that would
see,
be-
even that has ethical issues. Practical implications of continuing ECMO support. Clinicians may understandably experience moral distress at the prospect of being asked to continue ECMO support for patients when cure is not possible. They may feel that their professional integrity is being challenged by demands for interventions they think are inappropriate. Moral distress debriefings and counseling sessions may help address these concerns. They never had counseling when I was training. I'll tell you what, we have become so incredibly different from when I first started
Well,
in this
yeah.
industry. And you
Completely
probably
different.
being in India, I'm sure it's
Yeah.
more like it was for me back
Well,
in
they
the
don't offer
70s.
counseling at all over
Dude,
there
are you
still.
kidding me?
Like,
What do you
no.
mean you need counseling? What's wrong with you? You
Over
know?
there, it's big taboo to go to counseling.
Suck
You
it up,
cannot.
Buttercup.
Like even people with like depression don't get help in India because they'll be
No.
like, "Oh, something's wrong with that guy.
Yeah.
He's going
Right.
and seeing a shrink."
Yeah,
Like,
you need to get yourself together here,
You need to
right?
get
Yeah, I
yourself-
understand. Practically speaking, providing ECMO support for patients, that's not to say that I in any way dismiss
No.
true clinical depression. I do think it exists.
Oh no, it's very real, Joe.
I think it is
I've
real.
seen it.
Yeah, it is real.
I've seen it. It's real.
Well, I think I don't think you can be a human being and live in this world and live any duration of life at all and not have experienced it, frankly. I think we have transient periods
Yeah.
of time where we all have experienced
I
that
think
as a human species.
I think people don't understand what real depression is, and they
Yes.
just think being sad is being depressed. And
Yes.
they're not the same
No,
thing.
clinical depression is
Yes,
very
different. It's
and
very different.
very scary too.
serious, you know?
Practically speaking, providing ECMO support for patients who are not expected to leave the acute care setting requires that significant healthcare resources will need to be expended. Units dedicated to these patients may need to be created, which might raise questions regarding who would qualify for those units and how hospitals will be reimbursed given the current limited medical indications for ECMO support.
yeah.
In conclusion, when patients object to the withdrawal of ECMO, physicians should provide them with the support they need to continue engaging in activities that they find enjoyable and meaningful. They also should clearly describe to the patient all potential complications, limitations, and burdens that they may face and ensure that they understand that ECMO support cannot sustain them indefinitely. Palliative care teams should be consulted to provide emotional support and other needed services. Patients at the end of life deserve compassionate care from healthcare teams they can trust. Although they may not live to achieve the goals that the medical team had for them when they were first cannulated, it still may be possible for them to reach personal goals and build memories that will sustain their loved ones long after they are gone. Now, that I think is very that's very meaningful.
I agree a lot of what he's saying, but at the same time, I feel like he came from a high volume center that had 20 ECMOs on standby.
Clearly.
I mean, that's clear, right? Like
Clearly.
he clearly didn't come from a place that has 2.
Clearly.
Or maybe he wouldn't be so, like,
Yes, agreed. So now we're going to go into a rebuttal from Dr. Khan, and I'm a little confused because I only have 4, but he says 5, makes 5 points, and I shall address them.
Oh, okay.
So continued ECMO support is not futile. This is what our Dr. Childress said. This is correct. The term futile should only be used in the rare circumstance that an intervention simply cannot accomplish the intended physiologic goal. Clinicians should not provide futile interventions and should carefully explain the rationale for the refusal. Continued ECMO support is not futile because it furthers the patient's stated goal, to live longer. However, it may be deemed inappropriate, in which case it would be ethically supportable to withdraw ECMO even over the patient's objections. 2, quality of life. Here again, Dr. Childress is correct that quality of life determinations should be made by the patient. However, it is well established that respect for patient autonomy means that patients are free to choose from among the medically indicated options. If ECMO is no longer medically indicated because the patient cannot survive outside the acute care setting, that the patient has no right to demand ECMO. This is well established and supported by professional organizations, bioethics statutes, and statutes and case law. So different things. Avoiding cruelty in medicine. Although healthcare professionals should and do avoid cruelty whenever possible, how about avoid it whenever possible? I mean, man, I don't know where this dude, he's from Montana. I am not going to Montana. Okay, I'm going to stay in Wyoming. Listen, I'm sorry, Dr. Khan, but Cone, however you say your name.
I can't.
I may go to Wyoming, but I'm not going to Montana. That sounds like the train station to me. You're going to the train station from Yellowstone, if you remember that. Let's go to the train station right off the cliff.
Right off the cliff.
Although healthcare professionals shouldn't avoid cruelty, it is naive to believe that we can always avoid making difficult choices. Healthcare is rife with difficult decision making. For example, on the battlefield, there are often too many injured for all patients to receive treatment. It is the duty of the healthcare professionals to triage those who have a reasonable likelihood of survival above those who will not survive, even when those who will not survive are begging for treatment. I'm gonna stop it right there for a second and just say that I think that is I'm sorry, Dr. Khan, but I think that's a bullshit argument. This is a false equivalency of a battlefield, a war zone, or a mass casualty event, or whatever you may want to call it.
Right.
One is chaotic and totally uncontrolled, almost unmanageable.
Right.
And the other one is totally controlled with more than enough time to actually do polite hand wringing and eat a sandwich and drink a cup of cappuccino before you make the decision that, sorry, buddy, but we need the bed.
Yeah.
We need to clamp or miss whatever. Here's the clamp. Do it yourself.
Yep.
I'm sorry. I totally disagree. I think that using this triage idea in a war zone is a very, very poor rebuttal argument. I disagree with it entirely and somewhat wish he had not used it. Similarly, during the COVID-19 pandemic, providers needed to allocate limited resources. Again, we're talking about essentially
yeah.
what was a mass casualty event
Exactly.
every single day for 2 years.
Right.
To those patients who had a reasonable chance of surviving, denying those resources for patients requesting life-prolonging care, but whose likelihood of survival was low. Indeed, many triage protocols during the pandemic included taking ventilators from patients unlikely to survive to provide ICU care to others whose prognosis was better,
I mean, it
even
did.
over the patient's objections.
They were right, but was it
These
ethical?
are difficult choices, but
Yeah.
at times they are necessary in healthcare.
He's right.
Precedent.
They did that.
That's true.
Yeah, they
Yes,
did
it
that.
is true. But
Yeah.
again,
again, is it ethical to do that?
well, I mean,
You know?
well, I mean, is it ethical to do that? I mean, I don't think
Because that was a
ethical,
crazy time.
but I don't think we were ever taking ventilators from patients who were absolutely cognizant and able to talk and able to communicate and saying they don't want to die. I want to stay on the ventilator. I'm okay with living like this. Again, I feel like his rebuttal arguments are not comparable. I
Sure.
don't feel that. I feel like he's using arguments, but I don't feel that they're equivalent arguments
Right.
to what we were talking about.
No, they're not.
There's too many other factors that are confounding to this, and they're
There
not
is.
good arguments. I just disagree.
And
I mean,
he's
that's it.
using troubling and trying times where times are, it's different than it would be, like, you know what I mean? The context is different, like you were saying. Wartime decisions versus normal everyday
Yes.
decisions.
Or
can't
COVID.
compare, or COVID, right.
You
You
know,
can't compare pandemic
pandemic.
decisions to everyday decisions. Those are
Correct.
different decisions.
Correct. I agree. Again, I feel his arguments are poor. I think Dr. Childress really, in my opinion,
Yeah.
his arguments were much more sound. I agreed with them much
Absolutely.
more. But he goes on, precedent of prior agreement. Here, Dr. Childress is mistaken.
No.
We often require
had the
further
reference.
consent when patients consent to treatment. It is not uncommon if a patient consents to surgery that part of that consent is that they will agree to treatment of post-operative.
all you got,
Where did it go? Post-operative. I'm really sorry, but I think I might have messed that one up. Let me see.
Oh, we're getting to the good part, Joe.
Well, wait. I want to find it. So just give me a second. I'll find the actual article. Just give me, if you'll just give me two.
Yeah, no problem.
Give me just 1 second. C. V.
Your buddy messaged, by the way.
Let me see.
Aksh.
Yeah, I don't use AI because it's stupid. Let me
To
see.
solve this problem right before we were on the air.
I think, is this it? Okay, here it is. Yes. No, this is the yes. I need the no. This is the
Point and counterpoint. Oh, you need the rebuttal.
this is yes. I needed the no. Google. Give me a second. I want to finish this thing. Command V. No. Search. That's children. Here it is. This is his. Okay.
No, it's the same thing.
As a pediatric intensivist.
No, it's the same thing.
Doggone it. Well, I mean, I'm clicking the right thing. No. That's still Dr. Childress.
There was if you go back into it, it's
Yes,
a link to
I
article.
think I found it. No. No, it's... Man, yes doesn't get a whole lot of links. You know what? I think we have... maybe this is it.
Yeah, it's the same
Yes.
thing.
No, yes, that's his.
Yeah, that's his.
And it's in the rebuttal.
But we don't have
None
that.
declared. Okay, I don't have it. I'm sorry. So we just have to end it there. I can imagine where it was going to go. I apologize. I should have been more careful about that. So I hope you will all forgive me for it. However, there's many more things that we could actually discuss. Futility in the age of modern mechanical circulatory support. That's a very good article. Duration of veno-arterial ECMO support and outcome and analysis of the ELSO registry is very important, and it coincides with this particular article right here. The two of them combined. Good reading if you want to do it. I'm afraid we're out of time. I apologize for that. We only got through the point counterpoint.
You did say that it was going to go by fast, though,
But
see?
it did. It did.
It went by really
did.
fast.
And thank you again for being here and doing this with me. I know you have a long drive tomorrow to go do a case somewhere.
I do.
And you're it's going to be an NRP case.
It is.
And good luck with that. But I
Thank
wanted to
you.
thank you so much for being
yeah.
here again.
Yeah, absolutely,
You're really a good friend, man. I
Thank you.
appreciate you very much.
Absolutely.
We will see you tomorrow morning at 8 o'clock. You're going to get me again. Just me though this
Just
time.
Joe.
Just me. I'm gonna
He's
phone a
gonna
friend
try
though.
to phone
tomorrow.
a friend,
I'm gonna
yeah.
phone a friend
He
tomorrow. We've
figured
got
out how to
figure.
do it.
We did figure it out.
Yeah.
David actually
He
is
used
who figured
AI,
it out.
He won't admit it.
I-
but
no,
I
I
used
didn't
AI
use-
for him.
Yes, I'm
'Cause
not
he
using
refused to
AI.
do
There's
it.
nothing intelligent about it.
He
We'll see you tomorrow
refused.
morning at 8 o'clock. Peace out.
All right.